but
Nice.
I'll be going to Florida in August.
Oh, let me know, ma'am, if in case you can stop
Sure.
here, then very good. Otherwise,
Sure.
I'll try.
We'll plan something. You send me
Yes,
your phone number, US phone
yes,
number.
ma'am. Definitely.
Hmm?
Yes, yes, ma'am.
Yeah.
Sure.
I got your WhatsApp phone is there with me, but
Yeah, yeah. I'll send my US.
sure. So you are staying in a hotel or something?
No, no, ma'am. Apartment.
Apartment.
Yeah.
Okay. Your mother is also coming to
Yes,
US?
yes, ma'am. 2 months later.
Okay.
So we are live on the YouTube. Now we'll start the meeting.
Okay.
So good morning to one and all. Welcome back to Saturday Club morning meeting. And today we have a very interesting topic titled as Is Osteoporosis a Pediatric Disease? I have not yet understood the meaning of this stuff. So that I will be very eagerly looking forward to what Dr. Puri Agarwal tells us about this osteoporosis, a pediatric disease. Dr. Purvi Agarwal is very well known to Baroda audience. She was practicing as a pediatric endocrinologist in Baroda some time back. Presently, she is in Florida, USA. She had done her MD Pediatric and PDCC Fellow of Pediatric Endocrinology. Presently, she is associated with University of Florida College of Medicine, USA. She has been ex-assistant professor TNMC and BYL Nayar Hospital, Mumbai. She was ex-assistant professor at Government Medical College and PIMSR Vadodara. And she worked with various clinics like T2T Hormone clinics in Mumbai, Moonlight Clinic, and KGP Children Hospital at Vadodara. So over to you, Dr. Puri Agarwal. Thank you for agreeing to be on this meeting in spite of the odd timings that you are facing. So you can start your talk now, and you have about 40-45 minutes of talk and about 10-15 minutes of discussion following that.
First of all, thank you, Satish Pandya sir, for such kind introduction. Yes, it is an odd time. It's almost 11 p.m. here. But at the same time, I'm very, very excited to meet all of you, though virtually. It almost feels like home. Baroda almost feels like home. So I'm more than happy to share whatever little knowledge that I have. Yes, so I'll begin my slide share. Can everybody see this?
No, we are not seeing your screen.
Oh. Just a moment here. Yeah.
Yes. Yeah. Just make it slideshow now.
Yeah.
Yes.
Yeah. Okay. So, good morning, one and all. Thank you for waking up so early and joining to hear this. I have tried to keep a common topic, which is of interest of course, all our adult physicians. But you must be wondering, why is a pediatrician talking about osteoporosis, or rather, why is this topic called a pediatric disease? We encounter this topic after probably 50s or 60s. Then why am I talking about it? So we will be looking into the details of this topic in next few minutes. Dr. Satish Pandya sir has already introduced me, but yes, for those who don't know, I have started my career in Baroda, and I'm very thankful to everybody for making such a nice journey. I have continued my career here at University of Florida, only for research purposes ahead. So I'll be contributing to research here. Okay, so the agenda today is about bone health, and how can we prevent osteoporosis in pediatric age groups. So we will go through this topic. The moment we hear about bones, the first thing that comes to our mind are probably orthopedic surgeons, orthopedic problems. But as static as the skeleton appears, it is much more dynamic. It is not just a structure, it is an organ which is acted upon by hormones, which releases hormones, has many functions to play. It's not just for locomotion, it's not just for structure or calcium storage or marrow storage. It is in fact an organ, and we endocrinologists have kidnapped this as also organ. We call it now as an endocrine organ because it itself produces many hormones. Few important ones are FGF23 and osteocalcin. This is just a view to show that however hard this bone looks like from the outer surface, it is very soft and cancellous from inside. Hence, it's very much prone for the osteoporotic or mineral disorders that we see in the later lives. So this inner matrix is what is probably almost 90% made of proteins, and on top of it, calciums and other minerals are deposited. I will just take 2 minutes to talk about bone structure so that we understand why osteoporosis happens and why and how can we prevent it. So cells contribute very less amount of bones. They're just 2%, but they are the game changers. They are like master blasters. They control all our mineralization and protein synthesis. On top of it, salts are deposited, of which calcium and phosphorus are important salts, on the matrix of organic matrix, which is almost made up of proteins. So if we remember the basic structure, that is cells, salts, and proteins, we will understand how we can prevent it from getting deteriorated. So these are the cells. I am trying to show these cells on a very simpler basis so that we understand the pathology and so we can prevent it. Osteoclasts are the one which causes bone resorption. Osteoblast causes bone formation. Osteocytes control them. So cells, organic matrix, and salts. This is all about it. Each and every factor can control our bone health. So have you ever thought that why we stop growing in the bone size after childhood and adolescence? What happens to us? Why don't sorry. Yeah, I'm sorry for that. Yeah. Why don't we continue growing in size in bones? What happens after childhood or adolescence? Yes, you can counter argue that epiphyseal fusion happens, but why don't we grow in thickness then? What is the problem? The problem is about that resorption takes precedence over bone formation after a certain period of age. Hence, even thickness stops growing after adolescence. So when I say that all the time that we have to grow our bones is only till adolescence, after that, whatever you do, whatever food or nutrition you have, you just cannot stimulate the bone to grow more as compared to the rate it is which resolved. And hence we stop growing both in thickness as well as length after a certain period of age. So this is a very nice diagram which helps us to understand our bone life in a gist. So this is the peak bone mass. That is, my peak bone mass density is decided only and only up to probably second decade. After that, all that can happen to my bone is just the decline in the bone mass. You cannot increase your bone size after mid-20s. This is the graph for a normal male. This is the graph for a female. Some degree of difference always is there in the peak bone mass, but this is the bone mass that you achieve in your puberty or probably second decade. After that, you just continue to decline. The decline is much more faster and at a higher pace in women, and hence they are much more prone for osteoporosis or low bone masses. So this diagram is kind of a gist of our bone life. You can see that after this second decade, this was the peak. Like all we had was our childhood. All we had was our first 2 decades to grow. After that, all we can experience is only decline. Nobody can stop this. So agree with me that you, me, everybody is going to lose bones. It's just that we need to build up good bone mass. We need to build good peak bone mass so that when we decline, we do not land up in osteoporosis. So this is the process. You must have heard of modeling and remodeling for bone formation and bone resorption. It is when remodeling takes precedence over modeling, that we experience faster rates of osteoporosis, and which thins out our cortex as well as weakens our trabeculae. So when I say that our peak bone masses are achieved in less than 20 years of age, then why do we see so many fractures in our adolescents? And that too more common in boys? I just said that they have higher peak bone mass. Has it occurred to you that why do we see more fractures then? Because of this phenomenon that we gain in height much more before we gain in peak bone mass. That is, our peak bone mass has a lag period. It follows our peak height velocity after a period of some 4 to 5 years, and that is the ages that 11 to 15-year girls and boys, in spite of having such high good peak bone mass, do develop fracture, because their body growth is much more faster as compared to bone growth. Again, I will refer to this diagram, that yes, we are achieving this peak bone mass only if all the factors in our life are playing good role. That is, our genes, our lifestyle, we are disease free, we are inflammation free, then and then only our children and adolescent can achieve this peak bone mass. If somehow your lifestyle is not good, if your nutrition was not optimum, you had some genetic problem, then you cannot achieve that bone mass. For example, let's talk about a child with some very severe uncontrolled chronic inflammatory disease. In spite of good genetic potential, some lifestyle factor has not let him or her achieve good bone mass and is definitely much more prone for osteoporosis. And hence, we need good genetic factors, good hormones, local factors, nutrition, and lifestyle to achieve this. This is like a graph. For this to achieve, you have to have everything in place. Even if one factor goes wrong, we cannot achieve this peak bone mass, and hence we will be much more prone for osteoporosis in later lives. So now, do you agree with me that it's a pediatric disease? This graph is just an answer to my question, that is osteoporosis a pediatric disease? Yes, it's indeed a pediatric disease, but the consequences are seen in geriatric life. You do not see the consequences in pediatric life only because the bone mass achieved by then is able to take care of your modeling, remodeling, resorption, absorption. After a certain age, that peak bone mass is not able to help you, and hence the onset is pediatric, the consequences are geriatric, and hence it is the duty of us, you, me, everybody, every physician, every pediatrician, to build good, healthy adolescents with good peak bone masses to prevent the geriatric osteoporosis. I wish somebody would have told me this earlier. So, what are the factors which affect bone health? There are certain non-modifiable factors and modifiable factors. Let's go through them each one by one. So, ethnicity, race, sex, age of maturation, genetic factors, nobody can modify them, but they play almost 40 to 60% role in defining your peak bone mass. However, this is in our hand. We have control over modifiable risk factors like nutrition, physical activity, endocrine factors, systemic diseases, lifestyle factors. So let's talk about ethnicity. You will not like to hear that, but we Asians fare badly on genetic factors for low bone masses. The highest bone masses has been seen in the ethnicity of African Americans or the race of African Americans. We being Asians are as such on a disadvantaged scale, and hence we should pay much more attention towards the modifiable factors. We all know that males are at an advantage for peak bone masses. So the difference between gender and peak bone mass or bone health is not seen up till puberty. All of them, prepubertal children, have almost similar peak bone masses. It is during the adolescence, during the puberty, that we see the difference between the two, and whatever discrepancy or difference is seen is being carried on later in life also. So for example, this is some 5 to 10% difference in peak bone masses, and hence they decline early, which is super added by the factor of menopause. And here they are less, the males are having less chance of entering into a zone of low bone mass or osteoporosis. Age of maturation, this also matters. So we need hormones, we need sexual hormones, both testosterone and estrogen, for inculcating good peak bone masses during puberty. So you can see that Z scores, that is bone mineral density, is very much affected and low whenever the puberty is of late onset. Similarly, on-time puberty is good. Early puberty can be of some advantage in girls, but not in boys. And hence, early puberty, some advantage is seen in girls. Late puberty is deleterious both for girls as well as boys. You see lower cortical as well as trabecular bone mineral density, and that too as low as -4.2% to -4.8%. So what happens in late puberty? Due to late puberty and a relative deficient sex hormone stage, your osteocytes are not functioning. Osteoclast, which was responsible for resorption of bone, is acting at much more higher pace as compared to bone forming cells, and hence it's a stage of almost resorption, and hence late puberty is deleterious for both sexes. For the similar reasons, if somebody is on a drug like aromatase inhibitor, or which decreases the sexual hormone levels in the blood, they are at the risk of osteoporosis. Similarly, for the same reasons, osteoporotic men have also been treated with estrogen receptor modulator drugs for the same reasons. Now, there are non-modifiable genetic factors. I will just talk in brief about them, but I will like to emphasize that yes, we cannot change the genetic factors. They constitute something 40 to 60% of our responsibility of generating peak bone mass. But at the same time, rest 40 to 60% is also in our hands. So let's understand what are the genetic factors and how we can modify them. So again, I will take you through these cells so that it's easy to understand. Osteoclasts, which are responsible for bone resorption, osteoblast for bone formation, and bone controlling osteocytes. So what happens if something goes wrong with the osteoblast signaling, the cell which was responsible for bone formation? If something goes wrong with them, for example, some genetic mutation, and it is producing much more bone, like it is producing abnormal amounts of bone, like condition like sclerostosis, this is also harmful. Even such thick bones of high bone mass are also prone for fracture. Some dysplasias or genetic mutation. This is some interesting I want to show, that genetic mutations in bone forming cells have been identified, which are known to cause juvenile idiopathic osteoporosis. You can see the ballooning of vertebrae, the wedging of and fracture of vertebrae. So these, some even small genetic mutations in this bone forming cells can also cause very early onset osteoporosis. Now, these cells, bone forming cells, are responsible for producing collagen, which is the main structure of our bone. If something goes wrong with the collagen, you can have conditions like this. So I would like to share this patient of mine who presented to us on day 3 of life with multiple fractures all over the body. You can see day 3 of life, no childhood trauma, and there is callus formation, which itself shows that it is an intrauterine fracture. So many rib fractures, which can actually make the condition lethal. I am fortunate to have made such groups of children with osteogenesis imperfecta. We treat them with bisphosphonates. We have formed these groups in Baroda as well as Mumbai, where they all come together every 3 monthly to take those injections, and they have, these both children have not fractured even once after birth. So such genetic mutations can cause very early onset osteoporosis. Similarly, this cell, that is osteoclast, it is responsible for resorption. If something goes wrong with this cell, what can happen? For example, the cell is not resorpting the bone, and hence you have such high bone mass. Even this is deleterious for bone health. Example like osteopetrosis, or it is functioning too much, way too much, and you have such early onset osteoporotic bones like Paget's disease. So we just saw that these were one gene defect in one cell which were causing such huge problems. But what about us? What about the general population or mutation free population? We have found that there are so many genes, like almost 50 to 60 genes have been identified in general population, which have small effect on our bone health and are responsible for osteoporosis. The good thing is that these are under research for therapeutic modulation. We can target these genes and we can address osteoporosis in geriatric population. So there are so many primary genetic bone disorders which can cause osteoporosis. One of them was osteogenesis imperfecta we saw. This is also our patient, like Ehlers-Danlos syndrome. Such early onset osteoporosis at 8 years of age was seen. I talked about osteoclast, I talked about osteoblast. What about osteocytes? So even this cell can go wrong and produce very early onset osteoporosis. One of the example is X-linked hypophosphatemic rickets due to FEX gene mutation. So this is the girl from Baroda. She came at 4 years of age with her father being operated for some bony deformity. She having rickets with genu valga. This was bad, her rickets was. We found out this genetic mutation, FEX gene mutation in the father, because we knew both of them are affected of the same disease. And now we could prevent the future generation from having the same mutation. So this is how research and clinical go hand in hand, and we can prevent such early onset osteoporosis also. Now let's talk about topic of interest, what you should do, what I should do, what our children or our future population should do to prevent the modifiable factors being going wrong and prevent early onset osteoporosis. So nutrition, we talk of good nutrition, we talk of having good food, but what do we mean by good nutrition? How do we communicate that this is what good nutrition for bones means? So we need to have both macronutrients, we need to have both micronutrients in place for good bone health. Let's talk about each of them one by one. So if you ask me how much protein should a healthy growing adolescent should take, you all know that something between 1.7 to 2 gram per kg that child should take. And after that adolescent period, after the second decade, something between 1.3 to 1.5 gram per kg should be our protein intake. But then you can ask me that which protein should I take, animal protein or vegetable protein? I'll come to this answer later. But has it occurred to you that yes, whole of our bone is formed of protein? So should I start consuming lots of protein? Should I start over consuming protein? Can it be harmful or will it be beneficial? So the answer lies here. So this is called renal acid load. Our bones cannot function in acidic environment. If we remember that, then it is this chart will make sense to us. More the basic the protein is, more beneficial internal milieu will it get to form bones. Hence, vegetables, proteins available from vegetables, juices, spinach, and raisins can fare better than the more acidic proteins which could be found in some forms of cheese. Hence, a balance of proteins is what is required if you ask me whether animal protein or vegetable protein. No, very high amounts of protein, like consuming super high amounts of protein, is also not beneficial because it will actually lead to bone loss. So adequate amount is the key, and maintaining pH of your blood is the key. Not consuming excessive acidic foods or acidic proteins is the key. After exercise, definitely you should consume protein to outweigh the muscular losses. So has anybody wondered why Virat Kohli or some or the other celebrities uh, advocate alkaline water, and how does it improve bone health? It is the same thing that I talked about. More basic your milieu is, more favorable it is for the bone. So there are many proponents for this therapy of alkaline water. Yet the final conclusion is yet to come, but this is what the basis behind having alkaline or basic water is, that it can prevent early decline of bone loss. What about fat? Should I stop eating fat or should I take good fat? So we all need essential amounts of essential fatty acids, including DHA, for good bone health. But what about high fat consumption, which is very much seen? It actually is deleterious because it prevents calcium from absorption in the diet. As high as 45% of your dietary calories, if comes from fat, it is very deleterious for bone health. What about carbohydrates? Do they affect your bone health? Good energy, you should maintain the calorie content of each of your macronutrient, but at the same time you should avoid the glucose peaks that you get from consuming high glucose foods, because it can actually cause calcium excretion from urine, and hence very high amount of pure sugar, simple sugar, should be avoided for bone health. Now, I cannot be stressing enough that it is all about calcium. When it comes to minerals, it is majorly about calcium. It is also evident from the fact that even the resistant states of vitamin D can be treated only with calcium. So bone is not only about vitamin D. Vitamin D is the mediator between bone and calcium. It helps the calcium to go into the bone. It is not only about vitamin D, but having said that, you have to have adequate amounts in blood to get that calcium incorporate into the bones. So this is the guideline for vitamin D supplementation and calcium supplementation in 0 to 18 years of age, given by IAP. On an average, our daily requirement is 600 IU per day. For adults, it goes up to 800 to 1000 IU per day. Calcium requirement in up to 18 years of age is up to 800 milligrams per day. In adults, it is something like 1 gram per day. As simple as that, 600 and 600. So if I say that I need to take 600 IU of vitamin D, why do I say that dairy products are not good enough sources? Like, you must have heard all our mothers and grandmothers telling that have milk to have good vitamin D. But I would rather counter it that it is not a good source at all. Let's have a look at the packet of Amul Taza. So this Amul Taza per 100 ml just gives 0.5 microgram, that is 20 IU. So even if I drink 1 liter of Amul Taza, I will get 200 IU. So I'll have to drink 3 liters of Amul Taza to get 600 IU daily, which is not practical. And just 150 milligram of calcium in 100 ml. So Amul also got this Calci Plus milk. Let's see how funny vitamin D it gives. It gives 0.75 microgram, which is something like 30 IU. So 30 IU, just imagine how many liters of milk I will have to drink to get that 600 IU. And hence dairy products are just not good enough sources of vitamin D or calcium requirement. So we have to rely on sunshine. Sun is the best source of vitamin D one could ever get. But the paradox is that we, in spite of being a tropical country, they say that we are almost our 30 to 90% of population is actually insufficient or deficient in vitamin D. We are a sunshine country and still we are deficient. Why are we at risk then? Probably darker pigmentation, probably our diet is low in calcium and high in phytates. Our food is not fortified. Some genetic factors play a role. There is a lot of pollution in the air, which prevents proper UV rays to reach to us, and changing lifestyles. Of course, we do not sit out to get sunshine in the peak time. So ideally, if you ask what is the sunshine dose, like what dose of sunshine should I get? I should be getting some 15 minutes of sun exposure to face, arms, and legs 2 to 3 times a week between 11 to 3. People with probably darker skin will probably have to get to spend more time. How much more is not clear, but it is much more effective than consuming the drugs or supplements. However, SPF 30 can also reduce vitamin D production by 95%. So yes, you'll get the tan and you'll get vitamin D. No tan, no vitamin D. So continuing on the nutrition and bone health. So socioeconomic factors play a role, both micronutrient, macronutrient. Some malabsorption disorders can prevent good bone health. Vitamin D deficiency. Even athletes can have, in fact, higher osteoporosis if if the exercise is not supplemented by that enough amount of proteins. So this is the bone mineral density graph of somebody with celiac disease. Mind it, even adults have high prevalence of celiac disease in our country, that the peak bone masses are very much low as compared to the general population in states of malabsorption. It is very sad to see that only vitamin D deficiency can cause such huge such huge deformities and such bad rickets. Okay. So talking about second important modifiable factor, which you and me can actually act on or ask our children patients to act on, that is physical activity. Now, just passing a general statement, physical activity. Okay, have physical activity. Will all physical activity improve your bone mineral density? No. So which physical activity actually helps in bone health? First of all, it was found that those children who were active in their childhood ages had almost 10% more bone mineral content as compared to children who were not active in their childhood ages. So even the thickness was more. Hence, childhood activity plays a role in your peak bone mass and geriatric osteoporosis. So which activity, how much activity, which type of activity? It is said that 20 minutes of vigorous activity 3 days a week with weight bearing, almost like 5 minutes of jumping is also weight bearing. Skipping is weight bearing. Mind it, swimming is not weight bearing. So if somebody who is a good swimmer does not mean will have good bone health. What is required is weight bearing for good bone mass. And that too, just for 5 minutes of that total activity duration is also enough, they say. However, in general, if you want to advise somebody or take advice for yourself, 20 minutes, 3 days a week with almost 5 minutes of jumping component. And at the same time, we have seen that children or adults with reduced mobility, like cerebral palsy, have such high rates of osteoporosis and low bone masses only because of the same effect of physical activity on bones. So again, it's an issue of old age. Why is a pediatrician talking now? This is my favorite comparison. I say that we are the policy agents. We physicians are agents. We can advise our customers to put SIPs, to pay installments, so that they have a healthier life ahead. So our installments will be good nutrition and good physical activity, being disease-free, so that you get good returns in later life. So as I said, if everything goes right, then you can achieve this bone mass. If you do not do the right stuff in your childhood or adolescence, you are unable to achieve your genetic potential. And here is where we play a role. Lifestyle plays such important role in adult life. So it's an interplay between nutrition and physical activity that we talk. Now, how can I not talk of hormones? A brief about how hormones and good hormonal health on bone health. So all the hormones, play a very important role in maintaining good bone health. So have you ever wondered why these endocrinologists advise on adult growth hormone replacement also? So there's an argument that growth hormone is just cosmetic and it is only for height, but no. If an adult, a child who has grown up as an adult now, who is a growth hormone deficient, is still asked to continue growth hormone even in adult life, though with no height benefit or statural benefit, because even growth hormone is very much required for adult bone health, or will have faster rates of osteoporosis. You can see after treatment, the mineralization is much more as compared to before treatment adult. What happens is that growth hormone increases the activity of bone forming cells and hence can delay the osteoporosis. Similarly, both hypothyroid, hyperthyroid, both the states are deleterious for bones. Hence, you need to have adequate TSH. Even suppressed TSH is wrong. Even high TSH is wrong for bone health. What happens is that in cases of hyperthyroidism, suppose your TSH remains less than 0.5 consistently, it stimulates the osteoclasts to accelerate its function, and you can have higher rates of bone mass decline. Similarly, parathormone is very much important to maintain our good bone health. It can increase bone resorption and higher rates of osteoporosis. I'll be happy to share a case with you. A girl, 8-year-old, who came to us with shock, kidney stones and genu valga, had a calcium of 19.3 with alkaline phosphatase of something like 5,000 and low phosphorus. Her whole skeleton was osteoporotic. You can see salt and pepper skull, like just at 8 years of age, such severe osteoporosis, genu valga, but such high calcium, like 19. There is severe osteoporosis even in the distal phalanges, genu valga. On radioisotope scan, she was found to have parathyroid adenoma. So this is just one example that even it's not only about calcium. Even a calcium of 19 can cause such bad bones. It's about the hormonal balances. Chronic systemic conditions which can affect our peak bone mass. So all inflammation is deleterious for our bones, be it SLE, be it TB, be it inflammatory bowel disease, or any sort of inflammatory disease. Any kidney disease can be deleterious to our bone health. Infiltrative diseases like thalassemia, leukemia, any sort of drugs which can affect our bone health milieu, like glucocorticoids, anti-epileptics, methotrexate, retrovirals, so many drugs can affect our bone health. It is not uncommon to find that one index patient with renal disease and the whole family turns out to have some form of RT. This is one case where I want to highlight that this child was having primary condition of autoimmune hepatitis. Still, she was referred to me only for presumptive bone health. See, when we treat a complex disorder, all our focus is on that disease, or all our focus is on that liver who is being treated with steroids and azathioprine. She did not have any bony pains or bony complaints. We did her DEXA scan. It was less than -2.5. She was first treated with calcium vitamin D. Then we had to give her bisphosphonate. So my one take-home message over here is that yes, we are treating one organ or one disease, but it can have various effects on bones, both the condition itself and the treatment, which can have glucocorticoids. So many factors can affect your bone health. So though suppose we are treating tuberculosis, yes, we have to pay attention to the lungs, but please do pay attention to the deleterious effects on the bones also. So we talked about bone mineral density, we talked about peak bone mass, but only DEXA scan cannot tell you whether your bone is healthy or not. Your bone geometry, microarchitecture is actually determined by high resolution CT scan. It is yet to be very much publicized in our country yet, but this is the ideal state of scan. Yes, DEXA scan does give a very good estimate of mineralization of bone. So we saw these non-modifiable and modifiable factors. Yes, I know we cannot play a role here, but rest 50% is in our hands to prevent such geriatric complications. So we talked that our body health affects our bones. Can it be vice versa? Can actually bones affect our body health? Have you thought of it? It looks such a dead organ, or rather skeleton. Can a skeleton affect your body health? Yes, that is why we have kidnapped this organ as our organ. It is known to produce two hormones, that is FGF23 and OCN. So osteocalcin, which is produced by the bones, is known to have good effect on pancreas and insulin sensitivity, on adipose tissue, on testes, fertility, hippocampus, memory. On the same hand, the other hormone produced, that is FGF23, is known to have good effect on phosphate metabolism, lymphopoiesis, immunology, immune system, and hence, though our body health also affects bones, but bones also affect our body health. Hence, it's important to maintain our good bone health. So take home message over here is that keep your bones strong and be healthy. It's not all about vitamin D. Vitamin D is just an interplay between so many other modifiable factors that we talked about. It is just one of the factors. I strongly believe this, that exercise and nutrition should be a part of our prescription. It's good that we, if patients listen to our talks, yes, it's very good. But I think we should emphasize on each and every visit that even to a healthy child, unhealthy child, whatever, any encounter should be stressed upon for exercise and nutrition. So how else can I emphasize that prevention is better than cure? So what you could have prevented in your childhood, you are facing now, or probably you are facing in your late life. This is the utmost example of prevention is better than cure. It is this whole, suppose I have grown 5 feet. My whole height was determined at probably 16 years of age. Similarly goes with the bone health. My whole bone health will be determined by my second decade. So it is very important to pay attention in those 2 decades of life for this adult onset disease. It is a vice versa. Bones can affect body, body can affect bones. And hence now at the end of the talk, I hope that everybody will agree with me that it's a pediatric onset disease, but with geriatric complications. Thank you.
Thank you, Dr. Purvi.
Yeah.
That was very interesting and very useful information that the onus is on us pediatricians to take care of bone health of our children so that in adulthood they don't suffer much. Thank you very much for that. Now it's open for discussion. Let me look at the chat, and there is Dr. Sulin Trivedi who has made some comment. Use of parathormone in geriatric age groups without estimation of parathyroid hormone level or calcium is being practiced by many orthopedics. Is it fair? And I want to understand how parathormone can be useful in osteoporosis, because as far as I understand it is osteoclastic. So there is something regarding some prescriptions doled out by orthopedic surgeons for bone health, and he wants your comments on that.
I'll just take one moment. Just a Yeah, sorry. Yeah, thank you, Dr. Shulin, for this question. First of all, yes, I believe that calcium profile, metabolic profile, parathormone levels, vitamin D levels, everything should be done before prescription practice. Having said that, a normal parathormone level does not decline the usage of parathormone. Even if somebody has normal parathormone level, can still be a candidate of parathormone treatment. Why? Because it stimulates osteocytes. It is known to cause a balance between remodeling, modeling, between a rate of resorption and rate of formation. Excess amount will cause resorption, but amount, or rather physiological amount, is required for balance between resorption and formation. and hence the rationale behind its usage. Yes, we should do the levels, but normal levels do not decline its usage. I hope I answered.
There's a question by Dr. Hemant Sant regarding, is it okay to use salmon calcitonin used by ortho specialists for healing hip fracture in geriatric practice?
It's a very good question, sir. So yes, calcitonin does exacerbate the healing process in geriatric populations. Again, I would repeat that normal basic metabolic profile should be done. In case of calcium deficiency or vitamin D deficiency, these hormones are not going to accelerate what is going to be helped by normal calcium supplementation or vitamin D supplementation. After doing your routine workup, if the person falls in severe osteoporosis ranges, then calcitonin and such usages are mandated, but not in face of deficient stages of vitamin D or calcium.
Any other questions? Yeah, Dr. Jagdish wants to ask. Yeah, Jagdish, please.
Thank you, Dr. Purvi and Dr. Satish, for this wonderful session in the morning. I have a lot of questions, but I will just restrict to maybe a couple of them. The first thing is, what is your opinion about this, quantitative ultrasonic bone densitometry screening for osteoporosis in adolescents? Is it a valid tool, or is it only? It's not been validated.
Sir, if I heard it clear, are you talking of DEXA scan?
No, quantitative ultrasonic bone densitometry measurement.
Yeah, sorry. Yeah. Thank you, sir, for such nice comment. At the same time, it is, I just mentioned very briefly about that it is not only about mineralization. It's also about geometry. It's also about architecture. It's also about your collagen networks inside the bone. That cannot be estimated by DEXA. Hence, DEXA is a very inferior tool in today's world to estimate your bone health. But this is all we have today. If you talk of the standards, like I have to know normal to say that this bone is abnormal. And those standards are known only for DEXA, unfortunately, in pediatric or adolescent age group. I would like to use quantitative ultrasound in adolescent. It is validated, but we do not have references. So without having references, we do not know whether this adolescent is having a normal quantitative ultrasound or abnormal. It is in the process, but yes, it is a higher tool if you ask me in comparison to DEXA scan, almost equivalent to quantitative CT scan for determining the architecture on top of mineralization. It's the conclusion that we can come from this question is that minerals are just one part. The other major part is collagen and proteins, which is not estimated by DEXA, which is estimated by CT or ultrasound. It's just that we do not have the normal reference.
Thank you. I think that is a challenge we faced. We did a small study of about 500 children, and we had difficulty getting normal values. You absolutely nailed it. I think that's the problem. The second question I had for you was, everybody talks about calcium, vitamin D, but what about magnesium? Is there any role for magnesium at all in bone health?
Yes. So when I say that calcium and phosphorus are the major elements or minerals, the other minor ones are magnesium, bicarbonate, and other salts. But the good part of magnesium is that it is so ubiquitous in our environment and foods. We usually do not face a magnesium deficiency unless genetically prone or unless on certain medications like pantoprazole or PPI for a long duration. So it is not generally talked about, but yes, if you ask me in order of importance, calcium, phosphorus, and magnesium. So it is a good important, it holds good importance. It's just that we are not very usual to be deficient in magnesium. So it gets less importance.
Right. Thank you. My last question to you is, many of the children in our country are either preterm or low birth weight. So does this tendency to osteoporosis leukopenia, which occurs in prematurity, continue to adolescence? Is there a correction that takes place? Do they get back to normal bone, health by the time they're adolescents, or are they challenged right throughout adulthood?
Yeah, it's an excellent question. It is actually, again, if you go through that famous graph that I was talking about, we continue to grow exponentially till our second decade. And that is very much challenged in our preemies in the first 2 years of life. They are somehow not able to catch up to the full metabolic potential by up to as old as 2 to 4 years of age. On top of that, NICU stay, acidic environment, acidic pH, so much calcium phosphorus disturbances. Yes, people talk of calcium supplementation, but phosphorus supplementation takes precedence in preemie, which is very oftenly missed. So yes, it has been found that their bone health are adversely affected. On top of that, I would add the hormonal changes that affect the preemie, that affect their bone health. They are growth hormone resistant for quite some time in their life, which is also deleterious to their bone health. So they are not able to achieve their peak bone mass somehow because of so many different factors by adolescence, and continue to be at risk in later life.
I think that is a very important thing to keep following up in a preterm baby or a low birth weight baby. And my final question to you is a suggestion as to how we can do a public health intervention to prevent the relatively very bad bone health that most of us have in India.
Trust me, what I said when I say that nobody can override exercise and nutrition. I mean it. If I write some URDI prescription which has paracetamol, some antihistaminic, I would still want to write exercise and nutrition below it. It's not the fault of parents, or it's not the fault of anybody. It's just so many misconceptions are there that, our daddy used to say ki doodh pee lo, achhe bones ho jayenge, but we saw what is doodh. It is just, I'll have to drink some 3 to 5 liters of milk to get that much amount. Nothing can override exercise and nutrition. It sounds like a very cliched statement. It sounds like a very small statement, but we saw that almost 40 to 50%, if can be modified by that, then nothing better than that. So I think it has to be ingrained in our heads that what is exercise. I cannot pass a blanket statement that do exercise. The person will go and exercise for 5 minutes or do swimming and come back. So when I say exercise, it has to be specific. 20 minutes, 3 days a week, 5 to 10 minutes of jumping or skipping. When I say nutrition, it has to be definite amount. It has to say that this much protein, this much calcium, this much fat. So I think we need to bring it in our daily encounter to prevent long-term consequences. I hope I was clear.
Thank you.
Thank you. This was the best question and best answer of the day, I would say. Jagdish, you have many more questions, but let us see if time permits, we'll take it. We have some more questions in the chat box. Dr. Hemant Sant has asked a very pointed question about what hormonal changes happens when one does isometric anti-gravity 20-second hold-up exercises, which challenges the central and leg quads muscles. Puri, you can read that question?
Yeah, I'm reading, sir. I'm reading. 20 seconds hold up. Okay. It's a very, I think, technological question. I will try to answer to my best, but I will also make it a point to read it again. What I'm aware of is that when you, when the muscles are stretched, the signals are conveyed between parathormone gland and muscles. I think what we are talking here is about parathormone. See, don't take me wrong when I say that modeling is as important as remodeling is. You cannot just prevent remodeling. You need to absorb bone also. So both are important. So when we say weight-bearing exercise, it actually creates some wear and tear. It actually creates some damage so that your hormones come in place, your bone gets resorbed by parathormone stimulated osteoclasts, which creates a pit on which new bone and new calcium is deposited. I think what you mean by the isometric exercise is that we create physiological wear and tear and make it a site for new bone formation is what the rationale behind weight-bearing exercises is. So both are important, bone formation as well as bone resorption. So that can be achieved by weight-bearing exercises. But I will make sure that I read up about this again.
Right. My stress is that 20-second holding is very important in weight bearing. People are doing excessive pushing, but my message, because I have been teaching physiotherapists for 20 years, I have learned this from them.
Okay. Amazing points. And I was not aware of holding up. I was aware of weight bearing, that it can create the wear and tear. But yes, as promised, I'll read up and I'll get back to the group.
Yeah, you can answer this in our chat box also, WhatsApp chat box.
Yes.
There is another question from Dr. Sulin, and that's about your suggestions for pediatric preparations. Should it contain vitamin D and calcium, or vitamin D, calcium, and phosphorus also while prescribing?
Okay. So again, then I would like to say that we from India, we are in a beneficial position nutrition-wise, because our plant-based nutrition is full of phosphorus. It is ubiquitous. It's there in our water, it's there in our food, it's there in our milk, it's there everywhere. So unless deficient or unless addressing a deficiency, there is no specific role of phosphorus prescription. For example, if you're addressing a premature baby, you will address phosphorus. In a term baby, you don't need to specifically address phosphorus. Having said that, there are calcium phosphorus salts also, and calcium carbonate salts also. It has been proven that calcium carbonate salts are better than calcium phosphate salts. So if you talk of a not high-risk child, not high-risk adult, having good nutrition, plant-based nutrition, a good amount of leafy vegetables, you don't need to specifically address phosphorus. If you're treating rickets, if you're treating a child with secondary osteoporosis due to long-term steroids, you're treating a child with a cancer who is on anti-cancer treatment, you need to address phosphorus. In general life, non-high risk patient, you don't need to address. It's about calcium and vitamin D and you are sorted.
Thank you, Dr. Purvi, for very elaborate answers. And thank you all participants for a very interactive session. Dr. Jagdish, Dr. Hemansan, Dr. Shulin. Now, these are kind of questions which bring out so much useful information. So thank you all. Thank you once again, Dr. Purvi, for being with us. And we'll definitely have you more often in future meetings. So thank you for being with us. And we end the session here. And good night to you.
Good night. Good night.